Phantom limb pain is pain felt in a limb that is no longer there, and it is one of the most commonly doubted symptoms in medicine, despite being one of the best documented. An estimated 40 to 80% of people who have had a limb amputated experience it. That is not a fringe complication, it is the majority experience after amputation, and treating it as imaginary is both wrong and a barrier to care. If you have been told the pain cannot be real because the limb is gone, that is a misunderstanding of where pain comes from. Pain is not produced by the limb. It is produced by a nervous system that is still entirely present. The published account of phantom limb pain describes a heterogeneous pathology involving cortical, spinal, and peripheral mechanisms at the same time. Put plainly, that means 3 levels are involved at once. The nerve endings at the residual limb are still there. The spinal cord segments that serve that limb are still there. And the region of cortex that mapped the limb is still there and still active. Pain generated at any one of those levels is felt where the brain believes the input originates. That location is the missing limb. This is also why a single treatment rarely resolves the problem, and why the condition has been so difficult to treat. This is not a small population. In the United States, there are an estimated 2 million people living with major limb amputation, with projections reaching 3.6 million by the year 2050. As that population grows, so does the number of people carrying a pain problem that many clinicians still address only in passing. So let us be specific about what the evidence actually supports. Treatment spans pharmacologic options, non-invasive approaches such as mirror therapy, and surgical techniques. The evidence base is uneven, and it is worth being precise about what has been measured and what has not. Start with mirror therapy. A systematic review and meta-analysis screened 2,094 articles and included 10 randomized controlled trials. It found a statistically significant reduction in pain with mirror therapy compared with control within 1 month. The size of that effect was modest. The standardized mean difference was minus 0.46. Patients whose pain had lasted longer than a year benefited more. Now, the part that matters just as much. The authors were careful about the limits of what they found. There was a beneficial short-term effect, but no evidence of a long-term effect. They noted that this may reflect limited data rather than an absence of benefit. That is an honest reading, and it is the one to carry into a conversation about treatment. Short-term benefit demonstrated. Long-term benefit not demonstrated either way. A separate meta-analysis compared mirror therapy with virtual reality. It pooled 15 studies, 8 of mirror therapy with 214 participants, and 7 of virtual reality with 86 participants. 300 people in total. Mean age ranged from 36 to 63. 77% were male, and 61% were lower limb amputees. Both approaches produced meaningful reductions on a visual analog scale. Mirror therapy gave a mean reduction of 2.54 points. Virtual reality gave a mean reduction of 2.24 points. There was no statistically significant difference between the two. The authors of that analysis noted that the small sample sizes meant that factors such as cause of amputation, site of limb loss, and time since amputation could not be examined. So these are real effects measured in modest studies. They are not settled dosing guidance. And on this evidence, virtual reality is not better than a mirror. Now, where does interventional care fit? Because the mechanisms are peripheral, spinal, and cortical simultaneously, treatment aimed at only one level often disappoints. Where a peripheral generator in the residual limb is contributing, targeted approaches are worth evaluating. Where central amplification dominates, that needs addressing on its own terms. Relevant options at this practice include peripheral nerve stimulation, spinal cord stimulation, targeted nerve blocks, and counseling for chronic pain, which is delivered in-house. Where the pain has a burning autonomic character that overlaps with complex regional pain syndrome, the relevant options are treatment for complex regional pain syndrome and RSD and ketamine therapy. That brings us to the question people most often arrive with. Why has nothing I have tried worked so far? Often the answer is that treatment aimed at one level cannot address a problem that is generated at 3. That is an argument for evaluating which mechanism dominates in your particular case, rather than repeating the same approach and expecting a different result. So here is what I want you to take away. You are not unusual. An estimated 40 to 80% of people who have had a limb amputated live with this. The absence of the limb tells you nothing at all about whether the pain is real. And the honest state of the evidence is that some approaches have measurable short-term benefit, that the studies are modest in size, and that the sensible next step is to find out which mechanism is driving your pain.